Hi everybody, Privyet. Hello everybody. This is Dr. Dhruv Bibra working as a senior consultant in New Delhi, India. Thank you so much for giving me this opportunity. And I hope I pronounced the hello in Ukrainian in the best possible way. And thank you so much for this wonderful invitation. And hopefully, one day when this pandemic is better, I get an opportunity to come visit your beautiful country and interact with you personally. So I have been given a few topics to talk upon. So I'll be starting my today with the first topic, which is on neuropathic pain. So with regards to neuropathic pain, I'll be talking about the how do we actually what the definition, the diagnosis, and the basic treatment guidelines, and then I will be adding my own experience that how do we interpret those guidelines to manage our patients on a day-to-day basis. At the end of my talk, you will have my WhatsApp number and my email, and hopefully I will be present when my talk is presented to all of you, so that you can ask me n number of questions and I will be there to answer them. So let us start from the very basics. What is the new definition of pain? As you all know, ISP has been giving us the definition of pain for a very long time. It gave the first definition in 1979. And last year, during the pandemic, they came up with a new definition of pain, which says that an aversive sensory and emotional experience typically caused by or resembling caused by actual or potential tissue injuries. So now, why did I start with this definition? Is because when we talk about neuropathic pain, or any pain for that matter, we try to focus a bit too much on the pathology rather than the sensory experience associated. Along with that, along with the sensory, the emotional experience associated with that. We try to focus ourselves more towards the sensory, the pathological conditions, rather than focusing on the emotional aspect associated with pain. Chronic pain, most common neuropathic pain, has a very important emotional aspect associated with it. And if we really want to take care of our patients, firstly, we should be aware of it. And when we are trying to manage it, we should always think that pain, and even neuropathic pain, is a very personal and an emotional experience. With that background, let us start with the topic of neuropathic pain. So what is the definition? Now, this definition of neuropathic pain was given to us by NEWSPIC, which is the Neuropathic Special Interest Group of IASP, which states that neuropathic pain is the pain which is caused by disease or lesion of the somatosensory nervous system. Now, I would just like to break it up for you so you are able to understand it better. First, pain, neuropathic pain is a symptom, not a disease. Second, if we have to diagnose that the patient is suffering from neuropathic pain, we have to find out the lesion or the disease which will justify that neuropathic pain. Now, how do we diagnose that lesion? We diagnose that lesion by means of imaging, neurophysiological studies, laboratory studies, biopsies, anything which will reveal that anomaly or that lesion. The same goes with this disease. If we are suspecting any disease which can give us an explanation for neuropathic pain, then also that has to be demonstrable by tests. Fourth point is that the lesion or the disease has to affect the somatosensory nervous system. So you have a symptom of neuropathic pain, then you have a demonstrable lesion or a disease affecting the somatosensory system. If all those collaborate and cause pain, then we diagnose it as neuropathic pain. Now, interestingly, in that article, they also talked about certain classical neuropathic conditions which do not satisfy this definition, like trigeminal neuralgia, like post-herpetic neuralgia. So there they have said that in that scenario, you can diagnose the clinical condition based on history. They further go on to add that sometimes you will have a difference between the clinical picture and the testing or the laboratory test. In that case, you can use your clinical judgment. Fine. So eventually what they want to talk is, yes, you need to get a diagnosis right by finding out the lesion or the disease. But if you have a very strong clinical suspicion of neuropathic pain, you can label it as neuropathic pain and manage accordingly. And during the course of my talk, I will be talking about a specific condition where we started using it and we got decent results. Now, these are American data which talk about that around 7 to 10% of the general population suffer from neuropathic pain. So after the definition, now what are the different types? Now, there are two basic types. One is the peripheral neuropathic pain, and then you have the central neuropathic pain. So what would be the peripheral neuropathic pain? The peripheral is something like a trigeminal neuralgia, where you have a neuralgic pain in the distribution of the nerve, post-herpetic neuralgia, peripheral nerve injuries, amputation pain, and radiculopathies. Now, talking about central pain will be associated with spinal cord injuries and post-stroke pain. And then you have conditions of disease like multiple sclerosis, which again cause central neuropathic pain. Now, there are some other ways or some other common causes of neuropathic pain, which have been illustrated here. Now, how do we diagnose it? Now, I will just like to take you to your OPD setting where you are seeing the patient. So a patient walks into your OPD with complaint of pain, having some symptoms like tingling, numbness, paresthesia, hyposthesia, which is suggestive of neuropathic pain. Along with that, the distribution of pain is in a neuroanatomical area of distribution. So you have symptoms and an area of distribution. Then what we are dealing with is a possible neuropathic pain. Now, in this case, in which we are suspecting, then the patient goes through certain screening tests, which are broadly classified as QST or quantitative sensory tests, which are a series of 13 tests in which we are trying to find out the various aspects. If they come out to be positive, then what we are dealing with is a probable neuropathic pain. So how do we confirm it? Going back to the definition, either we have to find out the disease or we have to find out the lesion. So how do we do that? The patient undergoes a battery of evoked potentials, reflexes, nerve conduction velocities, skin biopsies, corneal microscopies. So all these things will actually give us a proper confirmatory diagnosis. So clinical suspicion, possible, examination, probable, final diagnosis, final set of tests, and then you have definitive neuropathic pain. So when I got to know it, firstly, it took me time to understand it. And then I realized that with the amount of patients that I see in a day-to-day practice, which is around 50, 60 patients, it is practically impossible to do it in all the patients. So what do we do? So what do we do? So here what we have is the screening tests. Now, these screening tests have a good amount of sensitivity and specificity, and they actually help us crack the diagnosis of neuropathic pain on a practical day-to-day basis. But the proper way, which we have discussed, but on a day-to-day basis in your outpatient department, when you are seeing a lot of patients, so these come in handy. So we have got two cases. One is a pain detect questionnaire. Again, set of questions which the patient which you can ask, tell the patient, and all those things. Again, seems cumbersome. So now we have shifted to the DN4. It is very simple, easy to use. We have compiled a data, and very soon we will be publishing it, where we have tried to find out what is the incidence of neuropathic pain in our patients. Now, in this, there are 10. This is a questionnaire which has got 10 questions. 4 or more than 4 is if they are positive, then the patient is having neuropathic pain. So for practical purposes, we use this screening test and start the treatment. So now, interestingly, I also would like to introduce the audience to this concept of neuropathic itch. Now, what is neuropathic itch? Now, first time when I even heard about it, that, okay, you have an itch and then you have neuropathic pain and then you have neuropathic itch. It sounds confusing, but interestingly, the pathway for both neuropathic pain and neuropathic itch are same. Okay, so, and clinically, once you go to the DN4 and you have data, interestingly, in my practice also, I came across that there was a significant percentage of patients who always used to complain me that along with traditional neuropathic pain symptoms like tingling, like numbness, like hyposthesia, they always had that itch. And I always used to say that, okay, it is because of X disease, or I will ask them to go for a skin dermatology consultation. And then I realized that there is an identity called the neuropathic itch. And once I started documenting it, I found out that yes, in a significant percent, around 5-6% of the patients do suffer from this neuropathic itch along with that pain. Okay. And sometimes in herpetic neuralgia, this is the only thing for which the patient is troubled. Unfortunately, these kind of patients do not come to us, but as people managing neuropathic pain, we should be able to at least be aware of this, and then we will be able to manage it. As I told you, it is less severe, unrelenting, and as neuropathic pain, it also has a negative impact on your quality of life. Now, there is no definitive pathophysiology which has been discussed, but there are few theories which have been told to us, or which are there in the literature, which says that based on the intensity of the stimulus, the pattern of the stimulus, and the specificity of the receptors which are being stimulated, you can have two extremes. You can either have neuropathic itch or neuropathic pain. But most of the times, what we generally have is a mix of both with predominance of one. So what you will have is, if you are on this part of the spectrum, you will have more of itch, less of pain, more of stinging burn, right? Whereas if you are on the more pain side, then you will have an itchy burn. So basically what you get is a combination of both pain and itch. Very rarely would you come across clinical conditions where it's pure neuropathic pain or neuropathic itch. Now, so now when we have already discussed what is neuropathic pain, now we also know that there can be a neuropathic itch. Treatment of both of them are more or less same. So now let us talk about how do we manage them. Now, when we talk about managing neuropathic pain, so let us talk about the broad classes of drugs which are used, and then we will be talking about the various guidelines which are there. So let us talk about the most common ones. One are the TCAs, which are the tricyclic antidepressants. Then we have the SNRIs. Then we have the calcium 2 delta ligands. Then we have the topical lidocaine patches, and then the opioids, and last we have the Botox. So let us talk. So in tricyclic antidepressants, we have amitriptyline, nortriptyline, which are commonly used. Now, the problem with these drugs is, firstly, they cause a lot of sleepiness, a lot of sedation. So that is one big problem. Along with that, especially in males which are more than 65 years of age, they cause lot of anticholinergic side effects. Therefore, be very careful when you are prescribing them for more than 65 years old male. Then you have the SNRIs, duloxetine and venlafaxine. Now, the problem with them is they cause nausea and constipation. So that is one thing, and especially when you are using duloxetine with a combination of tramadol, then the chances of nausea increases. Then there is gabapentinoids, the most commonly used neuropathic agent. The gabapentinoids are either in the form of pregabalin or gabapentin. Then we have the topical applications of lidocaine patches and capsaicin patches. Unfortunately, we in India do not still have the capsaicin patches, but yes, we have we are using lidocaine patches for a long time. Only practical tip is that lidocaine patches are to be used for 12 hours and then removed for 12 hours. Then you again keep it for 12 hours. The local anesthetic toxicity and all those things are not a major issue in that, so you can go about it. Along with tramadol, now tramadol, the opioids that we can use is tramadol. We can also use tipendadol, which is coming up in a big way when we talk about the various guidelines. With tramadol, the problem is of nausea, constipation, but you need to reassure the patient that this is just a dose dependent side effect. So the moment you stop the drug, the patient will be fine. So this has to be loud and clear to the patient. And then we have the stronger opioids. Personally speaking, I am not a big fan of using strong opioids in patients of neuropathic pain unless the pain is having a VAS score of say 8 or 10 because of abuse potential, availability, and other reasons. Then we have the Botox. Not a lot of literature, but yes, it is also there somewhere in the guidelines. Now let us talk about the guidelines. Now, when we talk about the neuropathic guidelines, neuropathic agents guidelines. So basically what they have divided the drugs, they have divided them into the first line, the second line, and the third line. Okay, so if you go through them, so we have got around three major organizations which have given guidelines. One is the NewSpec, ISP, then we have the Canadian Pain Society, and then we have the NICE coming from the UK. So all of them, they talk about the basic drugs, that is the TCAs, specifically amitriptyline, duloxetine, gabapentin, and pregabalin as first line. Now these, if you go through them, all of them are in the first line drugs. So you can now, which among them, that you have to decide based on the patient profile, if there are any so-called contraindication of using one over the other. But the rest of them, based on the guidelines, more or less they are similar. I will be sharing few personal examples of how I use my drugs, but if you ask me just based on pure guidelines, all of them carry equal advantage. So there is no as such one over the other. You can choose anything which is available based on the patient and your clinical experience, but these are all first line drugs. Now the second line drugs, they come out as weak opioids. So what they talk about is tramadol. Tapentadol is still not there. We talk about tramadol, and then we have the capsaicin cream. Third line, interestingly, is cannabinoids. Again, cannabinoids is still not available, not for recreational or medical use in our country. So it's still coming up. So still no experience, but yes, it is a third line drug. And because it is available in Canada, that's why it is present in their guidelines. And then you have the fourth line, which is just nothing but of topical lidocaine. Okay, so just to give you a perspective on based on the drug lines, so we have the TCAs, the amitriptyline, nortriptyline, all of them have been given the first line drugs. Then you have the calcium channel, again, all of them, these are first line drugs. When it comes to SNRIs, NewSpix and Canadian, they have given second line, but mostly it is very effective. Then lidocaine for peripheral neuropathy. Now this is something which is interesting. For peripheral neuropathy, topical lidocaine is extremely good. Fine. So for example, if I have a patient of say herpetic neuralgia, intercostal neuralgia, post-thoracotomy neuralgia, post-surgical neuralgia, in that case, you can use it and it has got good results. Opioids, try to restrict your use to the weaker opioids rather than stronger opioids, and tramadol definitely is there. Now people who are practicing pain, they would be quite surprised that apart from these drugs, we are using a lot of drugs for specific conditions. For example, for all orofacial pains, we are using carbamazepine or oxcarbazepine. Some for headaches, we are using topiramate. So where do they find? Now, this is very interesting. And if you go through these articles, they basically talk about is that don't worry, these do not are first line for neuropathic pain, but they are first line for some specific diseases. For example, for I said trigeminal neuralgia, your first line of drug is oxcarbazepine or carbamazepine, but that is only the first line for that specific clinical condition, right? So you can have isolated drugs being used for isolated specific neuropathic pain conditions, but there is no generalization. So if a patient comes to me and I diagnose it as neuropathic pain, then I will have to give drugs based on the guidelines that we are giving. If I am diagnosing one specific disease like trigeminal neuralgia, like headaches, then probably I'll be using it. Okay. But they are, for example, I would not be comfortable using carbamazepine in other kind of, for example, radiculopathy. That's a neuropathic, so we don't use it. Okay, so it has got a specific use for orofacial pain. So that is one thing. So that is why they are not used as, it is used for specific conditions. They do have a use, not for generalized pain. Now, this is for evidence for peripheral neuropathies, where they talk about blocks. Yes, definitely steroid plus LA has got a weak evidence, Botox, moderate evidence, peripheral stimulation, again, moderate evidence. And as we all do in pain medicine, that precision is the key. So whether you are doing these nerve blocks, 5 fluoroscopy, definitely ultrasound has an advantage for better results. Now, we have had a discussion which is more of theoretical origin. Let's now apply the same principles to manage real case scenarios. All of these patients were managed by me in my OPD. So I'll be taking one by one, and hopefully at the end of the talk, you will have a practical application of how to prescribe these drugs. Had I been there in person, so I would love to have that interaction, but still. So here we had a 45-year-old male patient who came with back pain with radiculating, with a typical radicular right leg pain associated with tingling, numbness. There was no motor symptoms. So basically what this patient is having radiculopathy. Now, interestingly, for a very long time, radiculopathy was considered to be a typical case of nociceptive pain. But my dear friend, now things have changed. Now this was a very interesting article where they talked about that for a very long time, low back pain was considered and restricted to nociceptive pain, but this is not the case. In fact, now low back pain is looked at as nociceptive pain, neuropathic pain, and even with central pain, or which we call it as central sensitization. So it is a combination of pain. That is why when we are trying to manage, there is a rationale of giving NSAIDs, there is a rationale of giving neuropathic agents aggressively so that symptoms of central sensitization do not set in. What we are trying to do is there should not be any setting of central sensitization or a long duration pain, because that can really bring about a lot of long-term issues with the patient. Fine. So these are just the articles which have come in various journals which talk about neuropathic pain, a component of low back pain. And whenever we are prescribing, yes, in these patients, you need to prescribe. Now, the thing is, how do we prescribe? So this is what we do. I chose gabapentin. You can use pregabalin, totally up to you. So we start with 400 milligrams, depending on the body weight. Our population is comfortable with 400 milligrams at night, and gradually we increase it. Important point is we gradually increases NSAIDs and lifestyle changes. Now, next morning, the patient complains of heavy sedation, unable to wake up early, drowsy throughout the day. What do we do next? Now, this is people who have had experience of prescribing this would agree to me that it is extremely common to have these conditions. So what do we do next? Now, these are some practical tips. First and foremost, reassure the patient that this is a known side effect and it will gradually settle with time. Second thing, inquire about his lifestyle. When does he sleep? When does he have his food? When was the time when he had those medicines? Third, not to increase. You might have given a prescription where it says that every 5 days you consider increasing it. You said that don't increase the drug if you are not comfortable with the side effects. Fourth, ask for, is he taking any other medications which have a similar or which have or are sedative in nature. So you do not add sedatives, because with these gabapentins or calcium delta ligands, they cause sedation. And if you combine it with another drug which is sedating, then that can compound to a larger extent. Last, alcohol consumption. Now, this is something which you have to ask, that what is his alcohol consumption, and just try to restrict his alcohol consumption, because both of them, the neuropathic agents, especially alpha to delta ligands and alcohol, can cause a lot of sedation and cause a lot of problems. Important footnote. Remember, please inform, explain, and clarify all the above points while you are prescribing these neuropathic agents. Do not wait for the SOS calls. Fine, we have pain nurses, they are bombarded. Sometimes they get back to us that these things has happened. So be very clear when you are trying to explain the side effects when you are prescribing these neuropathic agents. Now, moving on to the 28-year-old female patient, actress by profession, complaining of widespread pain all over the body for many years. Lack of freshness after sleep, early morning tiredness, mood swings, DN4 is 9. So definitely we are dealing with neuropathic pain. So diagnosis is clear, is crystal clear. We are dealing with fibromyalgia. And again, a beautiful discussion point for this is one thing which a disease which is very close to me, because it is rampant, misunderstood, and has got a lot of social impact and social variation between various cultures and various countries. So always good to interact. and hopefully if we get a chance to interact, we will be talking about. So what we are dealing with is a basically fibromyalgia. So again, what do we do for fibromyalgia? Now, these were the three biggest guidelines which have come up for fibromyalgia, where they talk about ULAR, which is European, then you have German, and then you have Canadian. Now, for a very long time, pregabalin was considered to be the first line drug for for fibromyalgia. But now studies are rampant which say that there is no advantage of one drug over the other. So if you see, the best drug, what they talk about is the TCAs, and then you talk about anticonvulsants like gabapentin and pregabalin. Then we talk about SSRIs and SNRIs, tramadol and NSAIDs. So for them also, the choice of drug is TCAs, alpha to delta ligands, and SNRIs. Okay, SSRIs, the fluoxetine group. Now that is just for taking care of depression. It will not take care of your fibromyalgia symptoms. So this is more or less similar to all the guidelines that we have. So my dear friends, always remember, but what is the strongest thing? Sorry, I couldn't cover it is patient education. So if you have a patient of fibromyalgia, the thing which is actually going to give the patient long-lasting relief is patient education, actually telling and explaining the patient what is he or she is suffering from and how he needs to take care of his body and move forward. Now, co-prescribing. Now, this is something which I'm often asked because there are not a lot of data which has come out for this. That is one. Secondly, in our part of the world, we get drugs which are like a fixed drug formulation, which is not unheard of in the Western world. We do have fixed drug combinations. So when do we co-prescribe, or should we co-prescribe or not? Yes, there are conditions, there are neuropathic conditions where you have to, because you have to go for co-prescription. So how do we do? Firstly, there is inadequate effect. We tried one drug, the patient is not showing effect. Second is that on increasing the drug, you have side effects. So at the end of the day, we want our patients to function. We cannot keep on increasing the drug to a level where they start having sedation or they become non-functional. Third is consider switching the drug if there are side effects. So if the patient is having side effects, then you obviously need to stop it. Then sometimes we act smart and try to take advantage of the side effects of one drug over the other. Fine, I'll be talking in detail about that. Now, so for example, this is a 55-year-old patient complaining burning sensation in the leg. I found out that patient was diabetic and poorly controlled and had disturbed sleep. BN4 was 8. Obviously, we are dealing with diabetic neuropathy. Now, important thing is that his sleep is being disturbed. So we have to use something which will help which will help her in her sleep. So apart from using one drug of gabapentin, we will be complementing it with a dose of tricyclic antidepressant, because it will help you, which will help her in her sleep also. So this combination is going to work in this case. Now, these are the two questions. Now, all of you would agree that the most common patient that we come across is back pain. And after that, we have got joint pains. And among them also, the most common thing that we get is knee pain. Now, along with that, most common cause of knee pain is osteoarthritis. So these were the questions. Do you think that OA knee pain is a pure nociceptive pain, or there is some role of neuropathic agents in OA pain? Now, this is something that I would like to take you back to the time when we were discussing about how to diagnose neuropathic pain, when the last line was that sometimes you have to use your clinical judgment. Now, this started around 5 years back when we found out that long-standing knee pain or osteoarthritic knee pain, which has been there for a very long time, which has been ignored, what happens is the patient starts having rest pain, pain which is disturbing his or her sleep. So now that is the time when we realize that what we are dealing, okay, now boss, something is changing. Something is changing. There has been a change in the character of pain. From nociceptive pain, it might be turning into a neuropathic pain. And that is when we used our clinical judgment and started prescribing neuropathic agents. So therefore, whenever you come across any patient of any long-standing joint pain, always ask about paresthesia, hyposthesia, rest pain, and sleeping pain. Now, and then there are studies which gave us a good idea. This was a studies in 2012, which talked about around 5.4% of patients suffering from knee pain having neuropathic pain. 2017, definitely there was there. And this was our paper, which was presented by me in the World Congress, where we got a sample of around 500 patients and found a significant number of patients who had neuropathic pain. Anybody who would like to get the details, I will be more than happy to share them. Now, okay, so now moving from drug combinations to more advanced stuff. Now, this was a patient, 28-year-old patient, had a bullet injury, having paresis, excruciating burning pain in the right leg. So they had a fight and a bullet was there in the spinal cord, which was causing a lot of things. The patient had multiple surgeries. And after that surgery also, his pain was, he was already bedridden, but in spite of all that, his pain was not going, and it was a classical burning pain having a BAS of 10, impacting NDN4 of 10. So patient was in a lot of pain. So what did we do? This. Now, this is something interesting. Mostly people would be doing it. So this is also what we can do. This was a trial of a spinal cord stimulator in which we try to use neuromodulation or a neuromodulatory techniques to take care of this severe neuropathic pain. There is a separate identity physics behind it, so I won't be going into the detail, but I would like to tell you that yes, for neuropathic pain, neuromodulation can be used and is used to bring about this relief, because in this case, multiple drugs and all those things were not working out, and the patient required a spinal cord stimulator. So this was, firstly, we gave a trial lead. The patient was the trial was successful. The patient had 50%, more than 50% relief, and then we went ahead to give implant the spinal cord stimulator. Now this was the lead placement. Okay. Now, these are just some of the references which talk about yes, spinal cord stimulation should be used, and it is well tolerated as has got significant effect when it comes down to neuropathic pain. Now, one more important thing which I'm often asked by a lot of fellows who come to us for training, that how do we stop these neuropathic agents? When do we stop? So when do we stop? When symptoms improve or the patient has intolerable side effects. How do we stop? Now, this is extremely important. If the patient is on multiple neuropathic agents, we do not stop all these drugs at a time. We stop them one by one. That is one. Second is we consider tapering them also one by one. So we stop one and then we consider tapering the dose. In this case, you can see we stopped tramadol when we went to amitriptyline, and then we went to pregabalin, and then pregabalin also 150 to 75. It has to be individualized. You have to consider, though they are safe, you have to reassure the patient that these are safe. They can be continued for a very long time. But if you are comfortable, we need to, and you are able to carry on with your day-to-day life, there is a functional improvement, so we can bring a stop to it, but that has to be done gradually. That has to be done one drug at a time, and tapering the drug. So both of them have to be done. It has to be individualized. Now, this is the last thing before I say bye-bye. Now, this was something which is still not there, something which we have, and I'll be discussing our protocol when it comes down to this. So we had a patient of 65-year-old, patient had CVA, and post that the patient had neuropathic pain. So classically, the patient was suffering from central neuropathic pain. We tried all the pharmacological agents, but somehow they were not responding. So what do we do next? That is the time we have something like ketamine infusion, xylocard infusion, the pumps and the stimulators we have discussed. Now, for low resource countries like ours, because stimulators are costly and a lot of people can't afford it, and secondly, India is a large country, so there are a lot of variations with regards to training and infrastructure. So what we can do is, at any setup, is we can start with consider using intravenous ketamine infusion. Fine. So this is something which I really want you to have a take. I think if you want my presentation, you can have it. So what we generally do is we have a consecutive 3 to 5 days of infusion. It's a slow IV infusion which is given over 3 to 4 hours. Patient is monitored for basic monitoring is there. Starting dose is around 0.8 to 1 milligram per kg body weight. We increase the dose. There is a sequential increasing in the dose by 10 to 20% every day based on is the patient able to tolerate. Now, what can we expect is the patient can have some hallucinations, patient can become anxious. So in order to take care of that, what do? We generally pre-medicate the patient with midazolam, and we can even consider adding a bit of midazolam halfway through that infusion, right? So that we can take care of it. But trust me, it is the best and the safest infusion that you can consider. We started with that. If the patient, or sometimes what we do is we add 20 to 30 milligrams of propofol halfway through the infusion. So the patient is comfortable. And now this 20 to 30 milligrams is added for when we go for higher doses. So we start, say for example, we start with 0.8 and then we keep on increasing it, and now the dose is quite high. So in that case, along with midazolam, we add a 20 to 30 milligram propofol, which is given slowly over time. Fine. So again, it can be done in the least possible resource place, can be done with everybody, and very effective. Now, one more important thing is that if you go through the literature of ketamine, you will realize that ketamine is not only being used, ketamine infusions is not only being used for chronic pain, chronic resistant neuropathic pain, but it is also being used for chronic resistant depression. So if you have a patient who has neuropathic pain, causing along with that psychological issues, something like a depression, you can consider adding it, and you will be thrilled to find out the effects of it. Fine. Now, these are the few studies which have come up where it talks about, yes, it has a long duration of effect, but obviously there is not a lot of standardization, so there are not good quality studies which are there which supports its use. So before I end, I would just like to say, you should always, whenever you are seeing the patient, always classify the pain based on history and examination. Try to use neuropathic pain scales more and more. If you are in academic and you have the time, you can go through the entire thing. QST again is very simple to do, things which can be done on a bedside. So, but on a practical basis, just take a detailed history, examine the patient, follow the screening tools, you get a diagnosis whether you have neuropathic pain or non-neuropathic pain or a mixed pain. So always start with first line neuropathic agents, start with lower dose and gradually increase the dose. Always tell the patient what the potential side effects which are there, and try to use them to their advantage. If required, multiple agents can be used. Do not hesitate. Consider using ketamine infusion. And as rest, try to incorporate and share and get the data from your own country. It will actually help us form a data which is more universal. And one more thing, again, fibromyalgia and neuropathic itch is something which I am quite passionate about. So neuropathic itch, if you get across, we can always have a good discussion, and hopefully when this record is played, I will be there to discuss it with live. This is something which we do it annually, so this is a conference. Hopefully we will be able to do it online also, so most of you are welcome. This is my contact details. Please feel free to ask any doubt, any questions, any queries, anything. It is a good way of exchanging, and hopefully in this process I will also learn from all of you. With that, thank you so much.